All right, so let's get started. Are there any sort of issues or problems before we get started? Okay. Okay, again, I can't see the chat while I'm presenting, so please let me know if there's any questions. Just shout out if you have anything. All right, so this review is again about these last two lectures that really covered neoplasia and starting on the GI tract. So neoplasia represents our last concept in pathology in terms of the kinds of things that we consider causing disease. So we've talked about things like inflammation, infections, inherited disorders, changes in hemodynamic flow. So neoplasia is again one of those concepts in terms of what might cause disease. And within the gist of it, as you saw in your lecture, these are sort of the major points within neoplasia to understand what it is. So the naming nomenclature, and really what is the difference between a benign tumor and something that is malignant, because clearly clinically we're really concerned about the malignant cancers. So how do they arise? How do we identify them? What are their patterns of growth that make them unique and easy to identify? And clinically, some of the most important concepts are how we describe cancers in terms of their stage and grade. And we'll go through that with the case studies. And of course, the concern is when they metastasize to distant sites, they make them, of course, harder to treat. So I added a little bit in our lecture as well of how we detect cancers and some of the general principles of treatment. All right, so the first study is entitled Gastric Adenocarcinoma, a funded gland type with signet ring cell carcinoma component. All right, so in this case study, we have a 79-year-old Japanese woman who presents with a dull feeling in her stomach. She had a history of a H. pylori infection 4 years ago. Now, again, think about, as we talked about, what might cause you chest pain. Think about the kinds of things that a patient might show up with that gives you sort of stomach discomfort. It's not all immediately obvious that it's going to be a carcinoma or malignancy. So think about kinds of conditions that may present. This is sort of rather vague. But nonetheless, in this patient, when they do an esophageogastroduodenoscopy, all right, they find a lesion when they're looking into at the gastric angle of her stomach. So we see this sort of here. And what it looks like is this bump coming out is a little irregular. Here you see a little bit better picture. It's sort of irregular. It's very heterogeneous. You see some hemorrhaging within it. So typically in some of our definitions, how do we describe these kinds of lesions? Is it exophytic or endophytic? Well, this one's going to be an exophytic lesion because it protrudes out from the sort of surface layer. Something that's endophytic would have grown invasively down into the tissue. This is sort of coming out. All right, so simply we can already say it's an exophytic lesion, but it doesn't really tell us anything about what it is. All right. But when we take a sample of this, okay, and these are the pictures that they present in the case study, and here we see biopsies. Here's the sort of staining with H&E, and I think I described to you what the basis of H&E staining is. I think it's important for you to understand that because the vast majority of information we get is actually from H&E slides in pathology. All right. So what you see are certainly what looks like a lot of glandular elements. All right. But when you look at them, and it's unfortunately a little poor in the level of histology and magnification, but what you see is there the presence of what we see intestinal metaplasia. And so again, we talked earlier on about some of the initial cellular adaptations to stimuli that are usually temporary, and those are things like hyperplasia, atrophy, hypertrophy, but metaplasia is also one of them. All right, so in this case, when we say, what is the normal epithelium of the stomach? Well, it's usually just a simple columnar epithelium with a lot of chief cells and parietal cells. So what do we mean by intestinal metaplasia? Well, again, remember the term metaplasia as defined by those other forms of adaptation, and again, temporary, is the situation where we replace, again, if you look at this, they look like normal epithelium, right? It looks like something you would see in some part of the body as a normal adult differentiated epithelium. So metaplasia simply means the substitution of one differentiated epithelium with another. So if you were to look at it, you might say it looks completely normal. And in this case, of course, intestinal metaplasia means you replace that stomach epithelium with the epithelium that is normally characteristic of lining the intestinal tract. So again, it's a simple columnar epithelium, but in this case, it'll probably have a lot of microvilli on the surface, and you'll see goblet cells. So again, they look normal, but it's in the wrong place. Again, this is contrasted with hyperplasia, which we've talked about before, which is just normal increased cellular proliferation. And again, this is going to be contrasted with dysplasia, which is where we're starting to see, again, abnormal growth, but now the proliferation is not so orderly. It's a little distorted. We're starting to see a little bit of a loss of the normal architectural polarity and orientation. And we start to see a little bit of abnormal changes in the nuclei. And again, dysplasia can kind of keep going and become more and more disruptive till we get to the point of anaplasia, where as we'll see in some pictures I think I have later, there's just complete loss of anything that looks normal. So it just looks like a mess of things that you really can't even identify as any particular tissue type. And there's another term that we use in the cancer field called desmoplasia. And this is usually where there's an increased production of extracellular and connective tissue material, again, usually because the fibroblasts have been stimulated to go into hyperoverdrive. They are not malignant, but it's usually in a background where there's an epithelial carcinoma cancer that produces a number of growth factors or hormones that cause the fibroblasts, again, go into hyperoverdrive. So the normal connective tissue looks a little unusual. I think if we've got those terms straight, those are important terms to remember in terms of how we describe these kind of tissues. Okay. Now, the histology also showed what we call signet ring cells. And if you see them here, here's a little one over here. It looks like almost like a round sort of circular cell, and there's like what looks like a little ring, a gemstone. There's one over there, there's another here, and if you pull this picture up on higher magnification, you'll see a lot more of them. So signet rings are very common in the general forms of gastric carcinoma. They are typically, as you can imagine, because they're sort of full of this sort of mucin material, they sort of make a lot of mucin and secrete it. We find them in some other cancer cell types, but for our discussions, I think we're going to limit this to sort of the characteristic of the standard gastric carcinoma. So think about, I've tried to put this in line with what are some of the other special cell types that we've seen that are characteristic of diseases. We talked about things like sickle cells, but we have, remember we talked about some things like the Sternberg cells, which we see in Hodgkin's lymphoma, Arrow-rods, which we see in AML. Remember those Howell-Jolly bodies, which we see again in some conditions like hereditary spherocytosis, that show their stress on the bone marrow trying to make more red blood cells in a hurry. So a lot of the red blood cells are extruded into the circulation without fully maturing, and you often see those Howell-Jolly bodies, which are little pieces of nuclear material that are still remaining. So think again, I'm trying to put you into this, again, the mindset of trying to compare and contrast and look at the whole global picture of things. All right, any problems so far? No? Okay, so we see this characteristic of these ring cells, signet rings. So if you say that, usually we're talking gastric carcinoma. They also stain what they call for pancytokeratin. Pan means just all keratin types. And what's the significance of that? This is where, you know, it comes back to some of your basic histology. If you remember your different tissue types, each had a specific intermediate filament, and epithelial cells express keratin. This is different from the keratin, that is the keratinized layer on the outermost level of a stratified squamous epithelium. But this is part of the intermediate filament structure, cytoskeletal elements. And again, we use this to partially identify where the cancer came from. And a lot of times in pathology, you're given a piece of tissue and you have no idea what's in it. You see this sort of what looks like epithelial glandular elements, but you can't be sure. So we do staining based on the intermediate filament type to tell us what's the basic tissue type. So keratins, as you remember, are characteristic of epithelial cells. Vimentin is going to be characteristic of connective tissue. So if this was positive, we would say then obviously this is a sarcoma rather than a carcinoma. And so remember your intermediate filaments of muscle. There are different intermediate filaments. Remember that's Desmond. I think in histology you should remember what the intermediate filaments are for basically also for some of your neurofilaments, for nervous tissue. Again, we use this in pathology to help us define where the tissue came from. Histology gives us a really good idea of what the structures are. But again, if you're just looking at a tissue and you have no idea where these cancer cells came from, this is one of the first steps in starting to identify what is the cancer type. Again, review your intermediate filaments. Okay, so also when they looked at this, they said the tumor cells had slightly enlarged nuclei and started to show some mild nuclear atypia. What does that mean? Well, we talked about there's a very important feature in cancer cells. They show what's called an enlarged nuclear to cytoplasmic ratio, meaning the nucleus starts to become more and more enlarged as the cells progress from normal to malignant. They start to show things like many more nucleoli. Again, they're becoming just a bag of dividing cells, and they jettison a lot of the extraneous cytoplasmic material. So the ratio of nuclear to cytoplasmic material increasing, and that's characteristic of malignant cells. And again, though they say the pattern is somewhat disrupted, the fundic glands themselves, where they're finding this malignancy, are relatively well differentiated. So you see some atypia, but generally, again, when we look at some of this glandular material, it still looks like something that you would recognize as normal histology. But nonetheless, some of the tumor has, again, invaded into the submucosal layer, which means it has transgressed the basement membrane. Remember, we would sort of keep sort of pounding this at you. Once you disrupt the basement membrane integrity, you now have officially an invasive cancer. This is usually from an epithelium. So again, but the lucky thing is when they examined this patient, there was no evidence that the malignancy had progressed any further into the vasculature or into the lymph node. So it looked like at this point it was maintained within that tissue, that organ of origin. So again, this is they're diagnosing the patient with a gastric adenocarcinoma of the fundic gland with signet ring carcinoma. Right? So again, what are the major properties? Again, when you think of a benign versus a malignant tumor. Again, benign are just going to be the slow-growing innocuous tumors. They're well circumscribed. They may not cause the patient any problem. We are concerned when they are malignant tumors, on the other hand, because again, they can spread, they destroy tissue, and they can kill your patient. So at the gross level, certainly malignant tumors have very irregular borders. They're heterogeneous in their appearance. They often, because they invade and destroy the local tissue, you often see a lot of ulceration and inflammation, as well as often hemorrhaging. These cancers typically grow rapidly, and of course, they can metastasize. And I know sometimes there's a term that sounds a little bizarre, but the cancer cells themselves and cancers as growth are in fact not mobile. I hope you understood that. I tried to explain that to you. When we talk about mobility, we talk about things like lipomas, where you can almost grab it in your hand and wiggle it. These carcinomas, malignant cancers, on the other hand, they sort of invade the tissue. So it's not like you can get your hand around it. So in that sense, they are not mobile. They do metastasize and travel, but they are not mobile in terms of satisfying what I call the wiggle rule. Okay. So it's not surprising that cancer cells, which destroy tissues, which grow quickly and spread eventually, the appearance of them at the histologic level is going to mimic what you see at the gross level. So histologically, again, you're going to see a lot of what we call cellular atypia. The nuclei look different. There are increased numbers of nucleoli. There's less cytoplasm, and what we call pleomorphism. Within those cancers, typically every cell might start to look a little different from each other, rather than being very similar. In normal cells, normal tissues, the cells look pretty much all the same. So you see a lot of changes again in the nucleus. You see mitoses, and again, increase, particularly in that nuclear to cytoplasmic ratio. All right, are we good so far? Any problems? Okay, keep going. All right, so we saw that again, there were enlarged nuclei, little atypia, but generally the glands still look well differentiated. It had invaded into the submucosal layer, which means it breached the basement membrane, but there was no evidence of vascular or lymphatic presence. So we have two very important terms in cancer, and again, please remember these. We talk about the cancer grade or stage. And again, it's always typically going to refer to malignant cancers. Right? And we talk about the grades as 1, 2, and 3, and this is simply referring to the histology of the cancer. Grade 1 means well differentiated. It looks very much like its normal tissue counterpart. And as we get to grade 2 and 3, we go through what we call moderately to poorly differentiated. It doesn't start, it sort of loses its normal histologic architecture. And again, the problem with this is, again, the higher the grade, the more poorly differentiated, meaning, again, those cancer cells now start to look very abnormal. and this gives us an indication of how aggressive a cancer can be. So on the other hand, if the cancer is restricted to the epithelial layer, okay, we now talk about, again, this is what we call a carcinoma in situ, or another term is called an intraepithelial lesion. So we also, within the epithelium, I hope you understand, we either call this a high grade or a low grade. So we talk about low grade, the cancer cells, and again, they are officially cancer cells by their histology, but because they are still contained within an epithelium, we call that sort of either, again, a carcinoma in situ or an intraepithelial neoplasm. So it's a bit of how do you see the glass half empty or half full? Do you want to call this a carcinoma or just a neoplasm? Versus a high-grade carcinoma in situ. Again, here we see the cells within the epithelium are still contained within the epithelium, but they look very different. They're starting to look, they're fast-growing, and they show a lot more atypia. So what, again, determines whether an in situ lesion is officially invasive? That's where we see the disruption of the basement membrane. And typically, if you need to see this and you can't see it clearly on an H&E section, you will stain the tissue with through immunohistochemistry for collagen type 4. And if you see disruption, you then know for sure that those cancer cells that were maintained within the epithelium have now sort of invaded into the underlying tissue. And as soon as we see even one cell that has sort of gotten its way through the basement membrane, now that patient is officially diagnosed with cancer. Right? So an in situ carcinoma, even though the cells might look as nasty as can be, if it's still maintained within the epithelium and with an intact basement membrane, you don't call that cancer. I know that sounds strange, but that's just clinically how that goes. All right? Okay. So the other important concept for describing cancers is their stage. Now again, grade refers to the histologic appearance of the cancer. The stage is where is this cancer located in the body. So we have stages 0 through 4. And stage 0 again refers to cancers that are basically in situ. So a carcinoma in situ or an intraepithelial neoplasm. Stage 1, again, now means the cancer cells have in fact disrupted and invaded the basement membrane, but they're usually localized to that organ of the primary cancer. Stage 2, they probably may go into nearby tissues, such as lymph nodes. Stage 3 is more regional, so it might go into nearby organs. And stage 4 is where we consider metastatic spread to distant parts of the body. Now, it's also important to remember that stage and grade don't always go together. You can get a high-grade, low-stage cancer, and similar, you can get a low-grade, high-stage cancer, or you can get low-stage, low-grade, high-stage, high-grade, right? It's always a bit of a mix-up. So it doesn't always go together. Obviously, the worst kind of diagnosis is where a patient is going to have both a high grade, meaning histologically very disrupted, and a high stage means this cancer has spread. So you're going to have a very difficult time trying to treat that patient and manage their disease. Are we okay with stage and grade so far? Yes, no, okay. I'll take that as a yes. Okay. All right. Now, the important thing is, outside of this sort of general way of looking at stage and grade, in particular stage, where the cancer is in the body, because different cancers behave differently, there are additional, what we call staging systems that started in different cancer types. And one of the most important ones is called the TNM system. It started in breast cancer. And that was, again, because if you look at the normal sort of standard staging criteria, it didn't seem to take into account the really important role of a lymphatic spread for breast cancer, all right? And since we found a lot of other cancers spread by their local draining lymph nodes. So an additional staging system was developed for breast cancer. And as you can see, the TNM stands for T based on the tumor size. Now we're talking very small tumors in terms of defining. T0 is in situ, T1 less than 20 millimeters, and 2 is up to 50 millimeters, T3 is more than 50, and T4 is, if you can think about the breast wall where now the malignancy is starting to kind of go and touch onto the rib cage itself. So again, it's going to be important, as well as oral going outward towards the skin. But again, the important thing of some of the people found with breast cancer is, again, the clinical outcome didn't necessarily could be really defined really on very local parameters in terms of the degree to which very local lymph nodes were involved. Rather than waiting for it to spread to the brain and the lungs, we could find very good correlations between simple lymph node involvement, which is what we call lymph node mapping. So the N part of TNM stands for no lymph nodes, one ipsilateral lymph node, meaning the first lymph node that drains that cancer at its site. And N2 is there's more than one typical ipsilateral lymph node. So the immediate sentinel lymph node, which is right near the cancer, and then maybe one downstream of that, or 2 or 3. Okay, and so then N3, you start getting ipsilateral, again, the immediate lymph nodes draining that cancer, as well as potentially axillary lymph nodes or contralateral lymph nodes. And the easy thing here with metastasis, it's either there or it isn't. So we have M0 or M1 for presence or not of cancer and in a metastatic state. So we apply this often in addition to the standard stage 1, 2, 3, 4, because it gives us information about the lymph node involvement. And that, again, will have importance for overall patient prognosis and outcome. So if we go back to our patient in this, we see that her overall cancer measured 28 millimeters by 14 millimeters. Again, this is a relatively funded, well-differentiated cancer with, again, the signet ring. But if we thought about this, and normally she would have been a stage 1 generally, and maybe a relatively low grade. But if we use the TNM score, well, she's only a T2 because of the size. There doesn't seem to be, as they said, no lymph node involvement in this patient, and there was no metastasis. So if we use that scoring method, she basically comes out as roughly a T2, N0, M0 for, if we use the breast cancer, the TNM scaling system. And you will find this TNM system is now very widely applied to many cancer types, not just breast epithelium. But again, it gives you an indication of the size and particularly lymph node involvement. So again, luckily this tumor had only invaded into the submucosal layer and had not really there was no lymphatic involvement. So again, that gave us an N0 designation in the TNM system and an M0. But had it sort of, what are the major steps? If it starts, any cancers eventually will spread to the rest of the body through the process called metastasis. And this is based on the fact that any tissue, in particular the cancers, once they get to be larger than 1 to 2 cubic millimeters, that amount of tissue requires a blood supply. It can't get enough nutrition from simple diffusion of nutrients in the tissue. So often these cancers will then themselves secrete VEGF. We know that promotes angiogenesis. And as a result, not only then does angiogenesis serve to provide cancer cells with nutrition, but it provides them a conduit to metastasize to other organ sites, other tissue sites. So again, as a result, for these cells to leave their organ of origin, they have to lose, typically in epithelial cells, they have to lose their junctional complexes between epithelium, which is usually a loss of ECadherin expression, and as well an ability to secrete a number of proteases that will degrade the basement membrane, things like gelatinase, to allow those cancer cells to wiggle through out of their normal confinement in the epithelium, and usually then to get into the vasculature. So if this was, again, so this is called an adenocarcinoma, the patient was described with. If it was benign, we just call it an adenoma. And I'll get to that nomenclature again, because sometimes that's a little tricky. But again, if this was a malignancy that had arisen in fibrous connective tissue, we'd call it a sarcoma. If it had arisen in bone, we'd call it osteosarcoma. I don't know if anybody was confused with the nomenclature. Is everybody all right with nomenclature? Yes, no, maybe?
Yes.
Okay,
Yes.
good. All right. Remember, it's the overall OMA rule. Everything ends in OMA. And if we're looking at the majority, again, of cancers are going to arise from epithelial tissues or connective tissues. So if they arise from epithelial tissues, is it sort of just a normal flat kind of epithelium? It might form what we call a papilloma, OMA, okay, papilloma. If it comes from any kind of glandular tissue, whether it's a sweat gland, a breast gland, I have no idea, any kind of gastric gland, the word adeno is added. Adeno means gland, so this is a benign tumor of a glandular tissue. If it's malignant, these same sort of descriptions work, but it ends in carcinoma rather than just simply OMA. So we have carcinoma, meaning it is a malignant tumor of epithelial origin, but we can call it squamous, basal, adeno if it comes from glandular. So again, this is sort of the nomenclature. And the same OMA rule applies to, again, the tumors that arise from connective tissue. We have benign ones, fibroma, osteoma, lipoma. And their malignant counterparts are, in this case, sarcomas, fibrosarcoma, osteosarcoma, etc. Unfortunately, the breakdown in the rule, because these last three, where we have hepatoma, melanoma, and lymphoma. Unfortunately, these are, in fact, malignant tumors and malignant cancers. And so these are just ones that, of course, you probably already know, but again, they represent malignant tumors, not benign tumors. Right? So in our patient, so she was diagnosed with an adenocarcinoma of the gastric glands. So again, carcinoma malignant, adeno, it came from a glandular element. Okay. So some of the other things that we get to when we're looking at cancers, the patient had a history of H. pylori. Was it any role possibly in the development of this patient's cancer? Yes, we have a number of what we call either pre-malignant or pre-neoplastic conditions, lesions, disorders, syndromes that can increase your risk of the damage that occurs to cells of them undergoing, again, malignant transformation. Again, all of this basically arises in the background of cell injury. So if the cells can't repair the damage, they can't adapt, they can't restore their normal integrity. After a while, the damage, again, either will lead to necrosis and cell death, it could lead to scar formation, or it could lead to uncontrolled proliferation with increasing number of mutations so that we get uncontrolled cell growth, and this can become, again, malignant. So we have a number of these either inherited or acquired, what we call pre-malignant conditions. Again, remembering these conditions in and of themselves are not a cancer, but while some of them will resolve, again, often a lot of them can progress. So some of them typically present in some degrees as a little bit of either hyperplasia, but mostly dysplasia, metaplasia, and carcinoma in situ. Okay. Hyperplasia by itself is not really a pre-malignant lesion, but we have to be careful when we see it because often, again, it might resolve, but if it doesn't, it can, in some cases, again, slowly increase and develop into dysplasia, and then dysplasia will eventually can go into malignant transformation. So all of these are not, again, malignant, but while some of them regress, there's always the risk when you see these conditions that they can continue and eventually become out of control growths and become cancers. So some of the examples, again, conditions that may exacerbate the development of a pre-neoplastic lesions, as we see in this patient, this chronic infection with H. pylori gives the patient a chronic inflammatory response that ended up resulting in damage, in metaplasia, and eventually the cells just can't handle it, and they sort of just respond by becoming malignant. But some of the other examples are things like chronic infection with HPV, Barrett's esophagus, liver cirrhosis. And again, most of these have in common, a lot of these, that again, they have a history of chronic inflammation. The cells just cannot stand and handle the damage in perpetuity. So eventually, the way they adapt and handle it is to undergo malignant transformation. And on the other hand, we have some inherited pre-malignant lesions, again, that usually result from the inheritance of one mutated copy of a tumor suppressor gene. And once the second allele of that tumor suppressor gene is mutated and becomes dysfunctional, often that will lead again to malignant transformation. But often in these situations, we look at retinoblastoma or familial adenomatous polyposis, where the tumor suppressor gene is called the APC gene. These often don't arise in a background of chronic inflammation. So it's just one tumor suppressor gene, and then the second copy is lost. Now, it's important to remember, I think you probably had this, I hope, in your genetics class, is that, again, when people inherit a mutation of one allele of a tumor suppressor gene, that allele is missing basically in every cell in the patient's body. It still is a bit of a wonder why we only get very often organ-specific malignant transformations. It doesn't happen throughout the body. Okay? So again, do all cancers, in the case of GIs, do all of them occur in the background of chronic inflammation? A lot of them do. Again, anything with H. pylori, celiac disease, Crohn's disease, a lot of these are caused, a lot of them cause chronic inflammation that can increase the risk of malignant transformation. However, a lot of these inherited genetic conditions like FAP or hereditary non-polyposis coli are not as typically associated with chronic inflammation. They just, all of a sudden, these cancers just arise, all right? So they don't have to have a background of prolonged chronic inflammation. Okay. So what was unique in this case study? Again, think about this. I had just in our class, and I really want you to just, this isn't that important, but typically, generally we say signet ring cells are characteristic of gastric adenocarcinoma. That's not exactly true. There are some histologic subtypes. In this case, this patient had a fundic gastric adenocarcinoma, and usually this type of gastric carcinoma is not typically associated with signet ring cells. So it was unusual that this histologic subtype showed up with it, right? So typically, again, these fundic gastric adenocarcinomas are very well differentiated, which was what we saw in this patient, but they're positive for, again, nuclear beta-catenin. They see altered Wnt signaling, but again, typically we don't see signet ring cells. So this patient was a little unique in that it was there. So in addition, this patient, again, presented in a little bit, we talked about the types of adenocarcinoma of the stomach are typically either intestinal or diffuse. And typically the intestinal type, again, is the result of a background of intestinal metaplasia, which the patient did show, and also had some signet rings, which are typically characteristic of the adenocarcinoma type, which is the diffuse type. So this patient almost had two types of adenocarcinoma presenting within one cancer type. So she was diagnosed with what was the majority presenting type of carcinoma, in this case adenocarcinoma, but the possibility is she might have had both intestinal type and some diffuse type of gastric adenocarcinoma. What's the standard of care for a lot of these? Again, it's going to be surgical cytoreductive surgery as best as possible, and depending on whether there is spread, we may then supplement this with some kind of therapy, either radiation or chemotherapy. And this is really important if the surgical margins show the potential persistence of either cancer cells or potential microscopic spread of disease. So that's, again, the idea of whether the margins are clean or not of malignant cells. Where do we have screening tests? Would patients like this have benefited from our standard screening protocols? Probably not, because we don't have standard screening protocols for gastric carcinoma. We don't typically every year put everybody through an endoscopy. We don't do whole body scans. The kinds of screening tests that we do have are typically things like Pap tests for cervical cancer, mammograms for breast cancer, digital rectal exams for prostate, and sometimes for some lower colorectal carcinomas. So again, there really typically aren't screening protocols for this kind of procedures. And again, colonoscopies usually only go up through the colon. They don't go that far up into the stomach. So it's really unlikely that we could screen for patients who might present with this disorder. On the other hand, we do have some serum biomarkers such as PSA, CA-125 for ovarian cancer that are not great, but they are somewhat effective in against, sort of being a flag for the potential for malignant presence. Again, none of these serum biomarkers are 100% effective. They are not present in all the specific cancer types. So again, we sometimes get a lot of false negatives and false positives. If the patient had undergone chemotherapy, what are some of the implications of patients that undergo chemotherapy? Well, certainly there is the development of multi-drug resistance. And as I hope I got to explain to you in the lecture, cancer cells are, if you think about them, are very smart cells. They see the chemotherapy, they see that chemical coming at them, and they try to upregulate any kind of cellular mechanism that could reduce the efficacy of that chemotherapeutic agent. So those are things like trying to increase metabolism of the drug. They may try to re-export the drug. They try and increase DNA repair capacities. And once any of these general mechanisms obviously are upregulated, you can imagine that if you treat a patient with subsequent drugs, again, they will be less effective because these cancer cells are somewhat immune to all forms of chemotherapy because, again, they have increased generic forms of resistance to drugs. And certainly that is a significant complication of cancer chemotherapy, as is the accumulation of drug toxicity in neuronal tissue, as well as in particular the liver and the kidneys. All right. On rare occasions, we see the development of what we call paraneoplastic syndromes. So these are other secondary conditions that show up, para, meaning around and associated with the neoplastic condition. They are usually either immune-based or non-immune-based. And the immune-based basically is that, remember, the body does have an immune surveillance system. It often recognizes the cancer cells as somewhat different from the normal tissue, but again, remember, it's still all your own tissue. It's not alien tissue that has invaded your body. So if your immune system tries to mount an immune response, there will be certainly often cross-reactivity with that immune response, not only to the cancer cells, but some normal host tissues. And often, for the most part, these paraneoplastic immune syndromes start to generate host antibodies that attack sometimes not only the cancer cells, but particularly neural tissues. So they have a tendency to generate onconeural antibodies, and that becomes a significant problem. The non-immune paraneoplastic syndromes are as a result of often those cancer cells producing a number of hormones or cytokines that disrupt normal homeostasis, and as a result, you can get any number of conditions, things like Cushing's disorder. You can get sort of a lot of bone changes, again, because the cancer cells themselves are mimicking normal function and, again, are exacerbating normal metabolic processes. Okay. So, do we have any questions about cancer, malignancy, the terms? No? All right. You're all good? Okay, then. All right, so the last lecture of this, right now for this, started to look now, the last 3 lectures of this course, we're going to now look at these 3 different organ systems, the GI tract, the male reproductive tract, and the musculoskeletal system. And now take those basic 9-ish concepts of disease and apply them to organ systems, because again, in medical school, we teach things in an organ and a system-based method. All right, so take these basic concepts and now look at the GI tract. And in this case, I'm really just looking at what I call the tube of the GI tract, from the mouth down the esophagus, the stomach, which is modified, to the colon. All right, and out. Not going to talk about the related ancillary glands like the pancreas and the liver. Okay, so we take the major concepts of pathology and what plays a role in the major diseases, for the most part, that we see, again, in the GI tract. All right, so we're not necessarily, as you can imagine, not going to see all of the concepts being prevalent for the majority of diseases. You can imagine changes in hemodynamic flow fluid flow are really not a big deal when we look at diseases of the GI tract, but you can imagine things that are inflammatory, obstructive, as well as malignant lesions and tumors are going to be important in this tract. Right. Again, it's basically a tube. So again, you can, and it's lined by epithelium, so you can get damage to it, infection, inflammation, malignant transformation, and because it's in a tube-like structure, it's subject to obstruction as well. So I pulled out a case study that's called a case of painless excision. All right. And in this case here, we have a young 8-year-old boy who complained of what they call an enlarged gingival boil. It's really more like sort of more of a pyogenic granuloma. All right. And, 6 months earlier, he'd had a lesion that had been excised, but of course, obviously, it seemed to have come back. But otherwise, the boy is pretty healthy. And again, you can see it's sort of very red, looks really painful to the touch. But again, when you touch it very easily, because it's so sort of vascularized, not surprisingly, it's going to bleed when it is touched. So they take out this again. Once again, they excise the lesion because there's really not much you can do. So again, when we see a lot of these lesions, what kinds of things in the oral cavity can we excise based on what we should do? Some things we can leave alone, and some can be treated with medication. So what kinds of things can be resolved on their own? Sometimes, sort of those standard canker sores that you get in your mouth, those little white lesions, they resolve on their own, usually within a few days. Acute gastritis can often also, again, in sort of the GI system, can resolve on its own. Things that can resolve by medication, things like infection with thrush, dry mouth, things that have more chronic infection, inflammation may need anti-inflammatory agents or antibiotics. And some of those sort of conditions that we see in the salivary gland, if they don't drain themselves, may need some kind of help either medically or surgically. So in the case of larger, sort of more benign tumors like fibromas, again, pyogenic granulomas like what this child sees, typically we remove them, but they sometimes can grow back. You definitely need to remove, certainly not the obviously malignant lesions that you see, but some of the pre-malignant lesions like leukoplakia, erythroplakia, and any number of the polyps, because again, there's often an increased risk that they might transform to malignancy. So in this patient, so again, I'm trying to think about this, give you some broader perspective, mix up and match up. What, besides salivary gland liathesis, which is basically stone, what other obstructive disorders have we talked about overall in the whole GI tract? Remember, it's basically a tube. So some examples that we can talk about at different levels of the GI tract, you see esophageal achalasia, we see esophageal varices, which are sort of large enlargements of the veins surrounding the esophagus, which can compress the esophagus. Certainly a malignancy in the esophagus can cause obstruction. Oscod can meconium ileus, we talked about that. A disease called Hirschsprung's disorder. There are a number of anatomical disorders that are either inherent, born with as congenital or acquired, such as hernias, adhesions, large polyps, and diverticulosis, again, colon carcinomas, a number of things that can cause obstructions. But what is the most common, if we're going back to the oral cavity, the malignancy, that is called a squamous cell carcinoma that is characterized by keratin pearls. And again, remember that, again, the epithelium of the oral cavity is lined by a stratified squamous epithelium. And this is showing you here a malignancy that has, of course, protruded into the underlying tissue. You see here what's called a keratin pearl. Remember, this is lined with a lot of keratin. And these sort of big keratin pearls, they almost look like little onions when you look in cross-section. Some people may mistake them for nerves when you look at it in cross-section. But this is characteristic of a squamous cell carcinoma. So wherever you have a stratified squamous carcinoma, if you find a keratin pearl, that is very distinctive and is definitely diagnostic of a squamous cell carcinoma. So if I'm going back to our patient, when they took out part of the tissue, they sort of started to see that this was very well vascularized. You can just tell almost by the redness in it, very red, and it had a lot of granuloma kind of features. So what, again, remember, what's a granuloma? What's granulation tissue? How does this differ from other forms of growths that we have seen? Remember, typically our granuloma is the histologic hallmark of a chronic inflammatory event. It is filled typically with a necrotic core of tissue. Often there's activated macrophages that are lined by lymphocytes and sometimes a bit of a fibrous layer to try and contain the damage. On the other hand, fibromas are just sort of dense connective tissue benign tumors. Erythroplakia is, again, sort of a red sort of flat lesion that often occurs on the surface. It can transform into malignancy, as can leukoplakia. And remember, these granulomas, again, are different from granulation tissue, which is sort of that provisional matrix that we see as part of the normal wound repair process. And likewise, again, an adenoma is, again, a benign epithelial glandular material. And throw all of these things out there so you start thinking about comparing and contrasting them. All right. So when we talked about this patient had a number of granulomas as part of that feature, and you certainly saw that when you looked, kind of looked in it, sort of this nice pyogenic granuloma. Look at that histologically. We saw the sort of granulomas present. So where else in the GI tract might we see granulomas? Some of the other sort of infectious or sort of inflammatory conditions associated with Crohn's, ulcerative colitis, even celiac disease, unfortunately has very few. So we very commonly see granulomas in Crohn's and ulcerative colitis, but rarely in celiac disease. So how do you differentiate these sort of inflammatory conditions? Remember, Crohn's disease is present throughout the large and small intestine, and you see multiple separate lesions. So we call these, so they skip. You see a lesion and then normal tissue, and then it skips to a lesion and back and forth. The other thing with Crohn's disease is those sort of ulcerative lesions are very deep. They go through the epithelium, through the mucosal layer, so they're often transmural. On the other hand, ulcerative colitis is almost always restricted only to the distal region of the large intestine and rectum, and is one continuous lesion. And the sort of ulcerating lesions that are characteristic of ulcerative colitis do not go as far down, do not as transmural. So luckily, actually, ulcerative colitis is a little bit better treated than Crohn's because we can surgically remove that segment of the GI tract, and the patients typically are fine. Celiac disease, on the other hand, is more of an autoimmune disorder where the body, again, is sensitive to glycine-4, and which is found in gluten, and you remove that from the diet and you have no problem. What other things might be present? Again, to remind you, in a lot of these inflammatory conditions, what would be suggested? If you took a blood sample, I'm sure you'd see high levels of white blood cells. You might see C-reactive protein levels that are higher. And what are some of the other conditions that would present in the GI tract? You're either going to see disruption of function that results in either material coming up through the mouth or down through the anus. So you're going to see either diarrhea or vomiting. So look at these gastric conditions. Our patient's not going to have either diarrhea or vomiting, but what would potentially show up as diarrhea? Again, think of, these are very sort of generic presentations. It's like what gives you chest pain, what gives you stomach ache. So what can present with diarrhea or vomiting? A number of conditions can, and I've listed some of them here. For diarrhea, we can certainly see any kind of GI infection, celiac disease, Crohn's, ulcerative colitis, marasmus, some colon cancer, and then typically things that cause vomiting are going to be typically limited to lesions in the stomach and above. So again, things that are gastritis of in the stomach, GERD, and potentially even injury to the esophagus. Potentially, that could be trauma, swallowing something that cuts the esophagus, or potentially, physical trauma, cuts and that sort of thing. So again, not surprisingly, people with sort of GI lesions will either show up with diarrhea and or vomiting, depending on the upper or lower sort of GI tract location of the disorder. Okay. So going back to our patient, after removing this pyogenic granuloma, the patient did really well, and eventually over time, we see that it was great. We needed to do that because otherwise the tooth wouldn't have been able to come through. So that's great. We see the appropriate dentition. Now, so this is again what the child had was sort of a pyogenic granuloma. It was a benign condition, but if it had been a malignancy, it probably would have been a squamous cell carcinoma because it was arising from the gingival tissue, which is lined by squamous cell epithelium. If we had gotten squamous cell carcinoma, that typically doesn't occur in a young child. The most common things that contribute to oral carcinomas are things like excessive tobacco use and alcohol consumption, as well as infection with the higher strains of HPV. Are we okay with this? Looking at some of these things? Any questions, problems? No, you're really calm. Be quiet today. Okay. All right. So going on a little bit more again on this GI tract, our second case talks about a high-grade neuroendocrine carcinoma arising in the background of FAP. And again, this is a patient who has a history of basically a gastroesophageal reflux. Okay, it shows up with epigastric stomach pain. Again, what are the consequences? Well, again, this long-term potential chronic inflammation anywhere within the GI tract, again, can promote metaplasia, and that is a risk factor for malignant transformation. So the types of esophageal carcinomas, we had two types. They are, again, they're all epithelial. They're either going to be an adenocarcinoma, again, adeno coming from a gland, or a squamous cell carcinoma. And they arise differently, usually in their anatomical location. The adenocarcinomas of the esophagus typically show up in the distal third of the esophagus, and they're typically associated in a background of GERD, and molecularly they're associated with P53 mutations. On the other hand, squamous cell carcinomas, again, we talked, those are characterized by the presence of keratin pearls. They occur a little bit higher in the esophagus, usually about the middle third, and they just sort of grow as a background of a carcinoma in situ that slowly grows and grows and eventually breaches its basement membrane. Now, regardless of the type, both are generally associated with a poor outcome in patients. The patients, again, typically what will they present with in terms of the kind of clinical symptoms? Besides potentially vomiting, they're going to show up with dysphagia, dyspepsia, odynophagia, and xerostoma. This means they have a hard time swallowing, indigestion, or it hurts when you swallow, and dry mouth. And so those are the clinical terms that are associated with these kinds of presentations. Excuse me. So in our patient, once they do an endoscopy, again, typically we think about doing this from the colon, but we can do it either from the colon going up to look into what's going on in the large intestine, but we can do endoscopy to see what's going on in the stomach and sort of early portions of the duodenum. And here what we see is, thousands of polyps, and these are all these little kind of croppings. Normally, again, the lining of the GI tract should be relatively smooth. And so again, we see polyps. And again, it's important to distinguish between polyps and papillary growth, all right? Polyps look like a section cut through broccoli or cauliflower. They have this sort of flowery kind of proliferation of the epithelial layer, but they are always supported by a big fibrovascular stalk. It looks like a stem, and within the stem you see fibrous material as well as a vascular component. So again, a lot of these polyps are often benign, but some become malignant. So typically whenever we see any, we take them out. On the other hand, a papillary structure is also an outgrowth of epithelium, but it is just the epithelial layer thrown into multiple folds. There is no big stalk or stem to it, all right? And that's typically the difference between how we describe a papillary presentation versus a polyp. And so we have a number of polyps that we can find in the stomach and the colon. A lot of them are the same, but they can be hyperplastic, inflammatory, And we sort of see in the stomach, we see fundic as well as what we call the adenoma, and we see the adenomas. Interestingly, for the most part, in patients with FAP, we typically see the fundic gland polyps. You can sometimes see in these gastric adenomas. And typically, again, why are they at risk? Typically, these fundic as well as these adenoma polyps are the ones that are at high risk for malignant transformation. The inflammatory polyps really are very benign. Often they self-resolve. And even though we see hyperplastic polyps might look bad and they sound nasty, often a lot of them are really benign. It doesn't, they rarely transform. But again, if you're doing an endoscopy or a colonoscopy, typically any kind of polyp you see, you take it out just in case. But again, remember there are subtypes of polyps with a greater risk for malignant transformation. So in our patient, all right, not only did we see all these polyps in the GI tract, but they saw again masses in sort of lymph nodes as well as 2 small liver lesions. And so how did they, why do we use imaging and when are they used for? So we have simple x-rays. They are of course the cheapest and easiest to use, but they look for calcified tissues. So while we use those again to look at normal bone fractures, they have a merit in mammograms because in mammograms we're looking for strange deposits of calcium, basically abnormal sort of components that would be part of milk production. Ultrasound, again, is important to determine whether a mass is hollow or solid, because if it's hollow, it may be just a simple fluid-filled mass, like a cyst. And we use a derivation of ultrasound called Doppler, which basically shows us vascularity. And again, if you start to see vascularity, that's probably a bad sign because it means there's something growing that needs angiogenic and vascular support. CT scans, as was done in this patient, are basically, very higher resolution X-rays, and they're able to reconstruct 3-dimensional tissue structures, and they're very good, again, at looking at higher resolution of soft tissues. Likewise, MRIs, which are sort of the next way up and step in costs, again, have even more improved resolution, excuse me, of soft tissue differentiation. So that's what we're looking for when we're looking again at a lot of these malignancies. We only use PET scans when we really want to look for metabolic activity because we use radioactive glucose, and most of the cancer cells are highly metabolically active, so they will suck up glucose like there's no tomorrow. And so we can visualize where a lot of these malignancies are. But again, remember there are a number of also highly metabolically active normal tissues, like a lot of neuronal tissue, particularly your brain, and so they will also light up normally on a PET scan. So in our patient here who shows up with, again, all of these thousands of polyps in their lower large intestine, if this patient presented with diarrhea, what would we have? We have a lot of different kinds of diarrhea. Potentially, I would think watery, because again, in the cecum, the colon can't really resorb a lot of water, so a lot of that water might flow out. But again, we have different types of diarrhea based on whether there is malabsorption of a lot of food, so that the diarrhea is often maybe a little bit more fatty. Sometimes if there is a significant lesion, there can be blood in the diarrhea. So again, it's somewhat helpful in understanding what kind of condition is present. Okay. So in this patient, again, when we found a little bit more, they found that this patient had a family history of a number of different cancer types. But again, it included stomach, lung, breast, ovary. And mutational studies showed that, of course, this patient was, again, a part of FAP, meaning they carried a loss of expression of one of the APC alleles in every one of their cells. So again, this is a condition, again, that is loss of a tumor suppressor gene, which causes an increased risk of malignant transformation. There are 2 other conditions where patients do present with FAP. This is a condition called Gardner and Turcotte syndrome. And in Gardner's is thought to be a subtype of FAP, where of course patients do show up with thousands of benign polyps. Remember, all of these FAP patients, the polyps in themselves are not malignant. They are benign, but if you If you have thousands and thousands of these polyps, the odds are at some point, if you don't do something about it, even one of these will undergo malignant transformation. So patients with Gardner's have this kind of condition, but in addition to this sort of GI presentation, they also end up with a lot of other benign tumors, which is sort of a little odd because, again, they particularly target the musculoskeletal system. So they often show up with things like dental abnormalities and some benign bone tumors like osteomas. And Charcot's, again, is a condition where patients show up, again, with a lot of benign GI polyps, but the polyps themselves are a little different. They don't look like the standard inflammatory or hyperplastic. They have a lot of what we call neuroendocrine cells in them. So they are a little bit different. So again, as I mentioned, this is a condition. FAP, remember, is a hereditary condition where patients inherit the risk to develop a lot of benign polyps. These are not inherited cancers. On the other hand, the other sort of hereditary form of colon cancer is that of patients who inherit the genes that are mutated in DNA mismatch repair, and that condition is called hereditary non-polyposis colorectal cancer. So in those patients, they don't show up with thousands of polyps. They just get a high risk for a solitary colon cancer to just show up de novo. We do have some differences clinically in terms of colorectal colon cancers that arise either in the ascending versus the descending colon. And so typically in the ascending colon, this occurs more commonly in women as they get older. There is often blood in the feces. Patients show up typically with weight loss, anemia, a higher TNM score, meaning these are typically more aggressive malignancies with a poor outcome. And these are typically exophytic masses, but even though they grow outside into the lumen, they don't form big obstructive lesions. They have a tendency to just sort of creep along the surface of the colon. In the descending colon, a lot of the carcinomas, again, more commonly occur in men. They can occur in a little earlier age. They present more with gastric obstruction and are often, some of them are, this is where we see the hereditary non-polyposis colon carcinomas show up. They have a lower TNM score. They somewhat have a little bit of a better outcome than cancers in the ascending colon. Now, what's important to remember is regardless of whether your colon carcinoma arises in the ascending or descending colon, histologically, they look the same. They may be both adenocarcinomas for the most part. Okay. So in our poor patient, the only way to treat this large mass of all those multiple polyps was do a total proctocolectomy, basically just resect that whole section. And again, that tissue, when it's excised, shows several polyps. Again, a lot of these are sort of normal-looking polyps. Some have endocrine sort of relationship to them. When they do immunohistochemistry, they find, of course, they're keratin positive. So they have, obviously, this is epithelial. So the patient here is diagnosed, in this case, with a high-grade neuroendocrine carcinoma, again, as the sort of the subtype of, again, the greatest portion of colon carcinoma present, again, although there are some other histologic types present. And unfortunately, in this patient, some of the regional lymph nodes are involved, and again, the MRI showed us that there were liver metastases. So if we try to apply, again, that TNM score, well, again, that large size of this mass is in the centimeters, so it's well beyond millimeters. So it's the T3, the largest size you can get without it sort of adhering to other tissues. I'm not sure, they didn't say how many lymph nodes where they were, so it's somewhere as an N2 or an N3, and because it had already shown metastatic spread to the liver, it's specifically scored as an M1. So I hope everyone's starting to understand this TNM scoring system. The patient was, of course, after surgery treated with some chemotherapy because, of course, there's metastatic disease, but developed, again, complications due to that, and probably would not have survived very long. So again, as we mentioned, what is the general mode of chemotherapy? For the most part, these are just really nasty drugs that target rapidly dividing cells to form some kind of DNA damage that will halt DNA polymerase activity. And unfortunately, the consequence of that is that there are a lot of normal rapidly dividing cells, such as the epithelium that lines all the GI tract, the epithelium that lines the hair follicles. So all of these are typically targeted as well. And unfortunately, though there was some chemotherapy, 3 months later, there was a reduction in the size of the liver lesions. But again, long term, this is probably going to have a poor outcome. So, any questions, concerns so far? Yes, no?
No questions.
Okay, you guys are really good. Or I'm boring you to tears. All right, so here are some sample questions. We have a 65-year-old woman presents with abdominal pain. Could be anything. Complains of bouts of diarrhea. Again, could be anything. But a CT scan reveals small heterogeneous endophytic masses limited to the appendix and the liver. We take biopsies from both of these areas, and they are measuring in the size of 12 by 6, 3 by 7 millimeters. And they're relatively firm, but again, that's just looking at the mouse. Histologically, we see that these masses contain necrotic central cores that are surrounded by atypical, poorly differentiated cells. So how would we describe these in terms of their grade? And the grade means histologically, what do they look like? How close to their normal histology do they look like? Their stages, are they confined overall to their site of primary cancer, or have they spread? So if we look at sort of our options, high or low grade, high or low stage, if we look at this, again, the answer to this is going to be they are high grade because they are poorly differentiated. Okay, remember, a low grade is something that looks like the normal tissue. So there's grades 1, 2, and 3. This is going to be a high grade carcinoma because it looks poorly differentiated, doesn't look like its normal tissue counterpart. Because it was present in the liver and the appendix, we already know then that obviously it has spread, so it's going to be a high stage, just in sort of its general terms. Are we okay with understanding, again, the stage and grade concept? So.
Yes, I understand.
Yes.
Okay, good, because this is key. You got this, you've got it all. All right. All right, another one we have. A 72-year-old man with a long-standing history of cigarette smoking, bad, has had several bouts of respiratory pneumonia over the past 5 months. Luckily, over this time, he took a lot of antibiotics. That's great. But now he seeks medical attention because he's seeing a whitish coating on his tongue, and he has embarrassing halitosis, bad breath. Physical examination of this sort of white stuff on his tongue shows it's pseudomembranous, and you can kind of peel some of it off. So what do you think he likely has? Does he have leukoplakia, oral candiditis, which is basically a fungal thrush infection? Does he have just sort of an aphantus ulcer, like a canker sore, because those look like little white lesions? Or does he have sialaginitis, sort of inflammation of one of the salivary glands? Okay, so when we look at this, of course, the correct answer here is going to be he has a fungal infection. Leukoplakia does come as a whitish sort of coating on your tongue, but you cannot scrape it off. It is sort of the cells themselves growing like that. A canker sore is just a little round, white, very well-defined lesion that, again, some of us, maybe most of you have probably already had at some point in your life. They hurt, but then they go away. He doesn't have inflammation of the salivary glands, but the fact that this lesion can be scraped off, it's white, it can be scraped off, and he had sort of a long treatment of antibiotics, which not surprisingly could destroy the natural sort of flora and fauna of the normal biotic biome in his mouth, which would again allow for opportunistic infection with fungus. And that's often one of the most common backgrounds where we start to see a lot of these fungal infections is, again, in a background of long-term sort of significant antibiotics, which sort of wipe out the normal, biotic bacterial biome. So does that make sense? Is everybody okay? Do you have any other questions, thoughts, concerns? Okay. All right.
think a few people are good. They put up thumbs up signs.
Okay, because I can't see any of that now until I go out of here. Oh, there I sort of see something. All right, if we have no other questions, I guess we're good to go. You guys get the hang of it. Have any questions, shoot me an email and we'll be back. I have our last Q&A 2 weeks from now. Again, the idea being we're taking these concepts, all of those 9 or so concepts that we talked about as potentially disease forming, and now applying them to organ systems. So again, if you look at the GI tract, what we saw is potentially some congenital anomalies in terms of distortions of the tract, but that's very uncommon. Mostly what we're going to see are chronic inflammation conditions, the formation of malignancies. So we don't see too many genetic disorders, outside of a few that cause cancer. But again, we have cancer, we have inflammation. We don't have hemodynamic disruption in the GI tract. So not surprisingly, of those concepts, not all are going to be so significant for the majority of diseases within that organ system. All right, so then we'll look at the next 2, again, are going to be looking at some of the major disorders as applied by our concepts in the musculoskeletal system and the male reproductive system, just so we can show you some ugly pictures. There's no other problems. I'll let you guys all go.
Thank you so much.
You're very welcome.
Thank you. Have a great weekend.
God. If I get anything. Okay. Okay, understood. Okay then. Bye bye all.